Now let's talk a little bit about the pathophysiology of atopic dermatitis. In atopic dermatitis, immune triggers stimulate the release of inflammatory mediators. And the whole process involves the barrier and its interplay with these various immune factors. So we can start at the epidermal barrier, where we can have anything from an allergic trigger, some nonspecific inflammatory trigger, Staph aureus, or even scratching itself, disrupting the barrier, passing through the barrier, and triggering the immune response. Now, the epidermal barrier itself is comprised of a variety of proteins and lipids. Most famous of these, of course, is filaggrin, which is known to be deficient in some individuals with atopic dermatitis, but there are a large variety of other proteins that are important, as well as lipids known to be deficient, like ceramides and long-chain fatty acids. The epidermis is also the site of innate immunity. For example, the epidermal cells, or keratinocytes, produce antimicrobial peptides, which are very important in reducing the risk of infection. The immune system in atopic dermatitis is fairly complex. Very important are dendritic cells and the T cells, as well as a variety of other immune cells, all of which elaborate cytokines and chemokines that drive the atopic dermatitis response. Most prominent among these cytokines are interleukin-4 and interleukin-13. These are Th2 cytokines. Interleukin-31 is another prominent cytokine that has been specifically related to the itch. And then, of course, interleukin-22, and in adults, interleukin-1, seen in more chronic disease, also are thought to play a major role. Now, it is the interplay of the barrier dysfunction, the immunologic response, but also environmental factors that are involved in triggering and sustaining the inflammation of atopic dermatitis. Among these environmental factors are climate and climate change, smoking, increases in skin pH, and certainly the microbiome. When we're talking about the microbiome in atopic dermatitis, what we know is that with flares, there is a shift towards increases in Staph aureus and concomitantly a reduction in the diversity of the microbes on the skin in these active areas of atopic dermatitis. We know that Staph aureus in itself produces factors that can trigger or exacerbate the atopic dermatitis, increasing the cytokines that drive it and also decreasing the expression of some of the important factors that make up the barrier. There's been increasing attention paid as well, however, to the reduction of some of the normal flora that are seen on skin with flares of atopic dermatitis. And there is increasing evidence that some of these microorganisms that are normally on our skin produce factors that reduce Staph aureus and in themselves may be helpful in suppressing the inflammation of atopic dermatitis.
Amy, it looks like the barrier dysfunction may represent the key factor for why somebody might or might not develop atopic dermatitis. And there's been a lot of attention paid to filaggrin deficiency or genetic abnormalities in filaggrin in these patients with atopic dermatitis. An interesting publication from your group actually recently showed, however, that filaggrin protein and RNA and gene expression in tissue of kids with atopic dermatitis appear to be normal. So the story is yet to be written, I think, in terms of some of the other contributors to this barrier, in terms of what other components of this barrier are important.
Yeah, that was a big surprise to us to see that the levels of filaggrin were normal in children in the first 5 years of life who were within their first 6 months of atopic dermatitis, when we took biopsies from lesional areas that showed barrier dysfunction, but normal levels, and we have a lot to learn.
Yeah, stay tuned.
Well, that brings us to biomarkers.
Yeah.
And biomarkers, of course, are looking at levels of things like filaggrin and also some of the immune cytokines and chemokines. It's important to mention biomarkers because this is an evolving area of interest. We expect that in the future, as these are better sorted out, they will guide us in diagnosis, in assessing the disease severity, in identifying subsets within atopic dermatitis that will allow more targeted therapy and will also help us to develop more targeted therapy as we learn what's important in subsets with atopic dermatitis. Ultimately, we're going towards personalized medicine and the ability to predict individual responses to medications based on the profile of an individual.